As a paid program, WFEA is not responsible and accepts no liability for any of its content. The opinions, views, and advice expressed during the show are solely those of its participants, and not those of WFEA, its advertisers, or management, and should be used as such, as every individual situation is different.
It's time for On Call with Minuteman Health, bringing you an hour discussion with New Hampshire physicians and healthcare experts on topics ranging from specific medical conditions to our changing medical system. On Call with Minuteman Health, helping you understand healthcare. And now, here's your host, Scott Colby.
Good morning, folks, and welcome to On Call with Minuteman Health. I'm your host, Scott Colby, and in the studio with me this morning is an emergency department physician from the Elliot Hospital, Dr. Amy Roy. Good morning, Dr. Roy, and welcome to the show.
Good morning. Thank you so much for having me.
It's great to have you here, Dr. Roy. And we're going to be doing a show today, listeners, that's a little bit different than what we have done in the past. And we're calling this Grandbaby Bootcamp. And Dr. Roy is laughing. She's giggling right now. And she's going to walk us through some of the do's and don'ts of being a grandparent and safety and prevention. And, you know, a lot of our listeners may have young grandchildren, and things have changed so much from when they were new parents, and we want to bring them up to speed. So, again, Dr. Roy, thanks so much for being here.
Well, thank you. I think it'll be exciting.
It will. It will. So before I do the formal introduction and talk a little bit about your education, your training, and your background, I would like to do a shout-out to some very dear friends of my wife, Carla's, and me. Vince and Maria are moving today to Florida. We have been great dear friends with them, of them. I don't know how you say it. I'm getting all emotional. But for about 20 years, and they're moving to Florida today. We wish them all the best. And the upside, Dr. Roy, is that now Carla and I have a place to stay.
Every cloud has a silver lining.
There it is. There it is. Heather's shaking her head. And yep, there we go. So let's move into Grandbaby Bootcamp this morning. So okay. Dr. Amy Roy, again, is a practicing emergency medicine physician at the Elliot Hospital here in Manchester. She attended medical school at the University of Vermont, completed her residency at Yale in Connecticut. She is fellowship trained in pediatric emergency medicine and did her fellowship training at Yale as well. She has a dual board certification in pediatrics and pediatric emergency medicine, and once again practices here in Manchester. Dr. Roy, this is going to be a great show. Grandbaby Bootcamp.
That's right. Get ready.
Let's get ready. So let's jump in. You know, one of the things that comes to mind when I think of how do we keep a young child or an infant safe, and what jumps into Scott's mind is SIDS. Right, and that seems like, Dr. Roy, it seems like something that when I was a young kid in the 1970s, it felt like we became aware of it. And I don't know where its roots stem from. I don't know how far back we knew about SIDS, but we used to call it cot death, right?
Absolutely.
So it's been around for a while. So help us understand that.
Yeah, so you're right. Death of infants in sleep has been around for thousands and thousands of years, and we used to call it things like cot death or crib death. Towards the late 80s and early 90s, prevention of SIDS, which is sudden infant death syndrome, became a real focus for pediatricians in this country and around the world. One of the biggest and most significant steps that we have taken, I think, as a medical community towards reducing SIDS is changing sleep position.
Mm-hmm. So maybe centuries ago, because as you said, it's been around forever, people thought it might have been more of the prevalence of a medical condition, and it appears to be something that's more environmental.
Yes. There's definitely a very strong environmental component to SIDS. There's still a lot that we don't know about SIDS. We know that not every baby is at the same risk for SIDS, but there is a very strong environmental factor, which is good for us as parents and grandparents and community members because that's something that we can change.
Mm-hmm. And SIDS occurs when the infant is asleep. Is that correct?
Yes. Okay. So we would call a death of SIDS when an infant dies in sleep, and they has to be a baby 1 or under.
Okay.
And when an autopsy reveals no other significant cause of death, and when a death scene investigation also reveals no other significant cause of death. So this is not a baby who accidentally choked on a button or had an unrecognized infection.
Great. And I want to be sensitive to any of the listeners who may be very close to this topic.
Absolutely.
Because I can imagine it would be easy to place blame, and we don't want to place blame.
No.
We need to understand it, and even the recommendations over time have changed.
They have changed. They're
so if
different than they were.
Right.
Absolutely.
So if the medical community has been debating the proper steps and positioning to prevent SIDS, then how can one place blame? Right?
Yes.
So we don't want to go
No,
there.
we should not.
But the American Academy of Pediatrics is very close to this issue, and they've endorsed certain positioning and things like that. So what is the standard now?
So the standard now really is to place all infants on their back to sleep.
Okay.
Every baby on there should sleep on his or her back at every sleep.
Okay.
We don't recommend exceptions for nap time. Sleep is sleep. And every baby should be placed on his or her back on every occasion.
So that's a really good point, Dr. Roy, and that is sleep is sleep. So, and as you said, SIDS can occur during nap in the middle of the day. It doesn't have to happen at 2 a.m.
And I think this is something for grandparents to be particularly aware of, because you may have visiting grandchildren and you may have a family there who's just going to be there for the day. And it is maybe tempting to put a baby down on a soft surface on his or her stomach because you think it's just going to be for a little while. But for a baby, sleep is sleep, and we need to be mindful of sleep position and sleep location on every occasion.
Okay. And I would suspect that this is something grandparents or if mom and dad are listening right now, they should have this conversation with grandmom and granddad, and granddad, right? To make sure, all right, listen, the current recommendation is the baby sleeps on his or her back. That's what we do.
Yes.
I think in the old days there were concerns about choking and things, but again, sleep on the back.
Yes.
Okay. Before we went on the air, Dr. Roy, you had mentioned the distinction between SIDS and sleep asphyxia. And sleep asphyxia conjures up an image of suffocation. And could you explain what it is clinically and what the distinction is to the extent we know it between the two?
So I think that's a great question.
Thank you.
SIDS is really a baby who is put to sleep, usually on his or her belly, and who dies, usually in the same position they were put down in.
Okay.
It doesn't necessarily mean that something obvious was blocking the baby's face and preventing them from breathing properly. In a sleep asphyxia, something has fallen onto the baby's face, or the baby has moved their face against something so that they can't breathe and are effectively suffocated. So we do not recommend that people use bumper pads anymore. We don't.
Really?
No.
They're really cute.
They are cute, but you know why we used to have bumper pads?
Heather's
you know
laughing
why
at me. They are. They're cool.
Do you know why they were really invented?
To prevent the baby's head from going between the spindles?
Yes. And now that the crib railing spindle distance has been so much reduced and so carefully regulated, that risk has really been eliminated.
Got it.
So now they really are just more for
show.
Decoration.
Yep.
But they are definitely a suffocation hazard for babies. The same thing with stuffed animals. In the same way, a baby should not be put into a crib with a boppy, which is one of those curved pillows that a lot of nursing moms use.
Is that like what you see on planes? Never mind.
Yes.
Yeah, you put it behind your neck.
Exactly.
Yeah.
Yes, but bigger and cuter.
Okay, of course.
But not a good sleep surface.
Okay. All right. Well, there were a lot of different do's and don'ts, and there are a couple other things that we want to get to, but if I'm not mistaken, we're bumping up against break right now. So Dr. Roy, let's cut away. Let's invite our listeners to call in today's show, Grandbaby Bootcamp. Any questions you might have about caring for your grandchild, prevention, injury prevention, safety, 603-669-1370 is the number, 603-669-1370. We'll be right back.
People are finally doing something about the rising cost of their health insurance. They're switching to Minuteman Health. Minuteman Health could save you $1,000 to $5,100 a year on your premiums. Enroll at MinutemanHealth.org. Savings based on healthcare.gov comparison of the lowest cost 2016 silver plans for all carriers in 03215 for a family of 4, 2 adults age 40 and 2 children under 21, all non-smokers. Provider networks, benefits, and cost-sharing amounts vary.
St. Joseph Hospital now gives you more room to relax inside our new wide-bore MRI, used to help diagnose possible injury or illness. Patients who might find conventional closed MRIs difficult to tolerate no longer have to sacrifice comfort for the quality of their images. St. Joseph Hospital's new MRI unit will provide you with a faster, quieter, and more comfortable MRI exam without that closed-in feeling. We offer appointments 7 days a week for added convenience, and we promise to provide your exam results as quickly as possible. Top quality imaging for precision diagnosis. Expert care in a stress-free, patient-friendly environment. The latest innovations and technologies. It's just what you'd expect from St. Joseph Hospital. To learn more about our new wide-bore MRI, visit us at stjosephhospital.com. That's stjosephhospital.com.
When your diagnosis includes the word cancer, you want your care to be the best possible. At New Hampshire Oncology Hematology, their mission is to provide expert and compassionate care for adults with cancer and blood diseases. Their providers are committed to their patients and their fight. All members of their staff value honesty, teamwork, and communication with patients, their families, and all members of the care team. You and your family will always be treated with dignity and respect at New Hampshire Oncology Hematology. To learn more about their cutting-edge care close to home, visit NHOH.com.
You're listening to On Call with Minuteman Health. This show is informational and not intended to be used as a way to diagnose or treat medical conditions or to replace an appointment with your medical provider. For immediate and medical attention, consult your primary care physician, call 911, or seek care at the nearest emergency department at a local hospital. And now back to On Call with Minuteman Health.
Good morning, folks, and welcome back to On Call with Minuteman Health. I'm your host, Scott Colby, and in the studio with me this morning is Dr. Amy Roy, an emergency department physician at the Pediatric Emergency Department at Elliot Hospital here in Manchester. Dr. Roy, once again, thanks for joining us.
Thank you so much for having me.
Oh, it's great to have you here. I'd like to invite the listeners to call in again. Today's show is Grandbaby Bootcamp. 603-669-1370 is the number, and Dr. Roy is happy to answer any questions that you might have. So when we went on break, we wanted to wrap up the SIDS and sleep asphyxia discussion and a couple more do's and don'ts that you had mentioned, but I learned a new term, and maybe it's because I'm a guy, but I didn't know what this term was, a layette. And apparently they're fun things for grandparents to buy for a new grandbaby coming along, but there's a lot in there that maybe we should stay away from.
Yeah.
So could you tell us what a layette is, or tell the guys at least what a layette is?
I'd be happy to explain what a layette is.
Thank you.
So a layette is the set of, like, first clothes, crib bumper, oftentimes a puffy blanket, maybe a pillow. It's usually basically a set of linens and clothing for a baby, which often looks very inviting and very cute and is exactly the sort of thing that a grandparent would love to buy because it's adorable and fun and seems helpful. But, in fact, there may be a number of things in there that are really not appropriate for babies anymore.
Yep. And those are?
The bumpers.
Yep. A
pillow. No baby needs a pillow.
Okay.
Absolutely not. That doesn't belong anywhere in a baby's sleep area.
Okay.
No puffy blankets. Nothing puffy like that should be purchased for a newborn.
Okay, very good. Now, when we met a few weeks ago, Dr. Roy, you had also mentioned some of the other things that can put a child at risk relative to SIDS or sleep asphyxia. You had mentioned overheating.
Yes.
Right? And could you discuss that just briefly?
So I think sometimes we as adults have this perception that babies can't get cold. And it's true, we don't want babies to get cold, but they don't really get cold a lot faster than adults do.
Okay.
So really, we want babies to be in environments, and in particular to sleep in environments, that would be comfortable for an adult. Mm-hmm. So if you're comfortable wearing a T-shirt, then the baby would be comfortable wearing just sleeping in a onesie or a sleep sack, kind of a light layer.
And that led me to another question that I had for you. What is a sleep sack? And again, maybe our listeners know, and I'm just really
we're getting you
socially
ready when
awkward.
You have grandchildren.
Yeah.
This is your Grandbaby Bootcamp.
Hopefully that'll be a few years from now. But what is a sleep sack?
So a sleep sack is basically like infant pajamas. So it is a top and sleeves, but then it ends in kind of a loose bottom, almost like you took the top of pajamas and attached the bottom of a sleeping bag.
Got it.
So that way the baby is warm and can move around kind of like they're in a blanket, but it can't move up around the baby's face.
Okay. So to wrap up SIDS, a couple other contributing factors, and it particularly a shout-out here, or a shout-out, I shouldn't say a shout-out, but a word of caution for the grandparents. For those of you who may smoke, please don't smoke in the house.
Absolutely.
When there's a baby there.
Yep. SIDS is definitely increased in homes with smokers. The risk is higher in women who smoke during their pregnancy, but exposure to environmental smoke, whether that comes from parents or grandparents, also increases the risk of SIDS.
Okay. And great. Well, I think we've covered that topic, and I really appreciate that. But Dr. Roy, what I'd like to do before we get into the next topic, which is a very important topic on car seats and proper restraint in a vehicle, I want to step back a little bit, because we're fortunate here in Manchester to have the resources of a pediatric emergency department at the Elliot Hospital. And I was remiss in not teeing this up at the very beginning of the show, but I think it's important for our parents listening, our grandparents listening, and the general public to understand exactly the breadth of services that are available at the Pediatric Emergency Department at the Elliot. So could you just give us a walkthrough?
Sure, absolutely. So the Pediatric Emergency Department at the Elliot Hospital opened about 7 years ago. Mm-hmm. We see probably around 12,000 or so children a year.
Wow.
Yeah, so we're pretty busy. And basically what we have developed is a small area which is separate from the main emergency department. Mm-hmm. It's actually already too small for us, and we definitely need more space. But back there we can accommodate somewhere between 4 and 6 children. Mm-hmm. We've really worked hard to develop a child-friendly atmosphere, so we have things like bubbles and toys for distraction and televisions and VCRs. We also have a really wonderful nursing staff who, most of whom have the special certified pediatric emergency nurse designation.
Okay.
Which means
that's important.
It is important, and we're really proud of them. And it means they really have special skills and special training that has made them very, very comfortable and capable in caring for the sickest children.
Does it also, to have a pediatric emergency department, I don't know if that's a formal designation or not, but it would seem to me that you'd also have to have specialized equipment.
We do, yes, absolutely. So we have lots of specialized equipment for really tiny kids. We take care of babies from birth and all the way through children up to 18. So we have to be able to accommodate a real range of sizes. Mm-hmm. So we do all of those things, and we really do our best to take care of kids and families in a really family-centered way. Mm-hmm.
And I'm assuming that you have at least a few pediatric emergency medicine physicians, board-certified pediatric emergency medicine physicians.
We are a group of 4 certified pediatric emergency physicians, and we work with a larger group of general emergency medicine physicians.
And this is a unique program to Southern New Hampshire?
It is. In New Hampshire, there really is only the Elliot Pediatric Emergency Department. Nowhere else has a separate, special, designated emergency department.
I did not realize. I assumed that the tertiary center up north did, but it doesn't sound like it does.
They do not. Not in
New Hampshire.
Like we do, exactly.
Right. Very good. Well, that's good to know. We have a lot of young kids in this geographic area, and it's comforting to know that we have the specialized equipment, the specialized training, and staff to dedicate to pediatric emergencies. So thank you, Dr. Roy, for painting a picture there for us. So let's move over now. We have a couple other areas that we want to touch on this morning for Grandbaby Bootcamp. Car seats.
Oh, yes.
And it seems like at this point, not to be flippant, but I'm going to be a little flippant, that you need to be in a car seat until you're age 35.
Or prom, whichever comes first,
yeah, right,
I guess.
Exactly. No, but in all seriousness, just like with SIDS, I think that public safety, the medical community as well, is evolving in their collective understanding of what is proper support and restraint in a car to protect our children. And again, I was being flippant. I mean, obviously we want our kids to be safe. But help us understand what the standard is today for car seats versus what it might have been 30 years ago.
Sure. Well, 30 years ago, I'm sure there was a standard.
Right, exactly. Right.
You were allowed to ride in the way back of your station wagon unrestrained with your picnic, and it was fun, but it wasn't safe.
Dr. Roy, do they even make station wagons now? I don't know that they do.
I don't think there's a lot of space back there anyway. So I think probably the biggest thing is the duration of time that children are supposed to spend in some kind of child safety seat.
Okay.
And then we should talk a little bit about the specific recommendations for infants and young children.
Great. So let's do that. So what is the duration of time? And I assume you mean it's the entire car ride, but I assume you mean up to what age?
Yes, you are exactly right. It is, of course, the entire car ride, and it's every single car ride. It doesn't matter how far you're going, how fast you expect to be going. It's every single time, and that's how you develop a habit in a child and in a family.
And you do. I remember, I mean, Mike, our youngest is 18, and I just remember when our oldest, who's almost 25, you do. It's a habit.
Yep, it shouldn't be something that you even think about. It's just what you do when you get in the car.
Right.
So here in New Hampshire, we had a fairly recent legislative change where we have extended the sort of scope of child safety seat expectations.
Okay.
So the expectation is that the law, in fact, is that the child remain in a child safety seat until they are at least 7 and this is important, 4 feet 9 inches tall.
Okay.
Okay. So if you have a small 7-year-old, they can be 7 all day long. They're not ready to come out of a child safety seat. One of my kids, he's 9.5. He's tiny. He is a really little guy. He's going to be in that child safety seat for a long time.
Yeah. Yeah. And it's because of they can act like projectile objects, right? Is that really what it amounts to?
Yes, and it's just when children are smaller, a conventional adult safety strap, seatbelt, will not hold them in place. So a lot of what the booster seat needs to do, which is what we would recommend for children basically who are over 6 and have outgrown a car seat with a harness.
Which is where your son is that?
Yes,
yeah,
so he's in a booster seat. A lot of what a booster seat does is it basically lifts the child up so that the seatbelt goes over, the lap portion of the seatbelt goes down low over the pelvis rather than around the abdomen, which can be very dangerous in a crash. And it also keeps the shoulder strap where it belongs over the shoulder, not up around the neck.
Okay, because you can see with a sudden jerking motion and a halt of the vehicle immediately that it could do damage to the abdomen or the neck if not positioned properly.
Absolutely.
And that's
the child will just slip right through the shoulder strap portion and it'll be like it wasn't there at all.
Okay. So again, New Hampshire law, 7 years and not 7 years and 4 foot 9 inches.
Exactly.
Okay. For a child who's in an actual car seat.
Yes.
So what are the recommendations for a car seat versus a booster seat?
Okay. So let's start from newborns.
Sure.
So when you take your baby home from the hospital, the baby should be in a rear-facing car seat.
Okay.
And that's been a recommendation for a long time, and I think most people are pretty familiar with that. What is a little bit different is that now we recommend that children remain rear-facing until they are age 2 and have outgrown their current car seat.
And Dr. Roy, rear-facing, but rear-facing in the back seat.
Rear-facing in the back seat, and preferably in the middle of the back seat, although that's not possible in every car.
Okay. And the reason that we say in the back seat is because of the dash airbags.
Absolutely.
Correct.
Exactly. The dash airbags, and it is generally further away from most points of impact.
Right. Okay. All right. So you said up to the age of 2? Or until the time they outgrow their infant car seat.
2 and have outgrown their car seat. Money convertible car seats will vary a little bit. They may be okay until 35 pounds. They may be okay until 40 pounds. So the child should be 2 and have outgrown their infant car seat.
Very good. Well, Dr. Roy, we're going to cut away for break. When we come back, let's get into the next phase of car seats and then move on to other topics. Today, Dr. Amy Roy of the Pediatric Emergency Department at the Elliot Hospital here in Manchester is in, and she is walking us through Grandbaby Bootcamp. 603-669-1370 is the number. 603-669-1370. We'll be right back.
We didn't start with the idea of a new facility, but as ideas evolved, they led to the Elliot at River's Edge.
Elliot Orthopedic Surgical Specialists is a group of highly skilled doctors.
We provide comprehensive diagnostic testing for sports injuries and other mishaps.
Whether we repair, replace, or reconstruct hips, shoulders, hands, or knees,
our doctors will diagnose and begin treatment plans right away.
I'm Dr. Mary Lee Soul.
I'm Dr. Jonathan Mack.
I'm Dr. Paul Scabetta.
I'm Dr. Martin Ross.
I'm Dr. Rob Parisian. Our complete orthopedic team is ready to treat you.
The Elliot at River's Edge is now home to the most advanced ambulatory health care in New Hampshire. It's also comforting to know that Elliot surgical specialists and the nationally acclaimed Elliot One-Day Surgery Center are at the Elliot at River's Edge off Queen City Avenue. Elliot at River's Edge. We're ready to get you back to your active life. For more information, go to elliotriversedge.com.
At Catholic Medical Center, we believe that excellence in healthcare and personal respect for our patients go hand in hand. From our primary care and laboratory services, the Mom's Place, to our minimally invasive robotic surgery, CMC meets your every healthcare need. Our expert specialists and caring medical staff are dedicated to being your lifelong partners in good health. CMC, leading the way with heart. Find out more at CatholicMedicalCenter.org.
When you have digestive problems, you need to turn to a gastroenterologist who listens and responds. An experienced doctor who knows the field and can effectively diagnose and treat your needs. New Hampshire Gastroenterology in Bedford is now opening a new office in Nashua. You'll receive the same superior and compassionate care from their dedicated team of trained gastroenterology professionals who give you the individualized care that you deserve. Call New Hampshire Gastroenterology today at 625-5744 or visit nhgastro.com for their 2 locations in Bedford or Nashua. You're listening to On Call with Minuteman Health. This show is informational and not intended to be used as a way to diagnose or treat medical conditions or to replace an appointment with your medical provider. For immediate and medical attention, consult your primary care physician, call 911, or seek care at the nearest emergency department at a local hospital. And now back to On Call with Minuteman Health.
Good morning, folks, and welcome back to On Call with Minuteman Health. I'm your host, Scott Colby, and in the studio with me this morning is Dr. Amy Roy of the Pediatric Emergency Department at the Elliot Hospital here in Manchester. And Dr. Roy is joining us this morning to discuss Grandbaby Bootcamp, and we are talking about car seats. Dr. Roy, once again, thanks for being here.
Well, thank you. Happy to talk about car seats.
Absolutely. And can you believe that the show's already half over?
No.
I know, huh? So I want to give the callers an opportunity to call in again with any questions they might have about safety and prevention. 603-669-1370 is the number. So we got through rear-facing car seats for infants up to the age of 2 or until they outgrow the car seats. We mentioned that the car seat should not be positioned in the front seat. If you're in a pickup truck, I believe the airbags can be turned off. And please, so next phase.
Okay, so at or about 2, when the child has outgrown the car seat, which is rear-facing, they should go into a forward-facing car seat with a harness.
Okay.
And they really should stay in that until they're about 6 years old.
Okay.
When they have outgrown the harness system, either by height or by weight, and they are 6 or over, that would be the time to transition them to a regular booster seat.
And for the reasons you mentioned during the last segment of proper positioning of the manufacturer-installed safety belt, that's why the booster seat is deployed.
That's right. So the booster seat helps to position the adult seat belt properly, and the harnesses provide additional stabilization for children who are smaller but who are also less skeletally mature. So even if you had a really unusually tall 3-year-old, they would still need to be in a car seat with a harness.
Okay. And again, New Hampshire state law, age 7 and 4 foot 9 inches tall.
Yes.
Okay. One of the things that might be tempting, though, is as the child matures or ages a little bit, and even though they might be in a booster seat, is the temptation to put them in the front seat. We want to keep the kids in the back seat as long as possible, right?
We really do.
Until they have an adult frame.
Until they have an adult frame. I think a good rule of thumb is generally 13 and up to sit in the front seat, but an adult frame is really essential.
Right. And so it seems like every generation our kids get bigger and bigger and bigger, right?
I know.
And we lose sight of proportion and perspective. How do grandparents know how to judge how large a child is? What is the right size? Mom and Dad should know this, and you know, Heather did mention during break that you can go to your local fire department and ask them for some questions about proper fitting of child restraint systems. But what are some questions, Dr. Roy? You said you found some.
Yeah, so I think there's a good little guide that you can use, because you may be picking up your grandchild for the weekend, you may be picking them up at soccer and thinking to yourself, do I need a booster seat? Should I bring a booster seat? I'm just not sure.
Right.
You can do some kind of quick tests. So the first thing is to see, can the child sit comfortably all the way back in the seat? So can they sit with their back against the seat? Are their knees bent comfortably at the edge of the seat? And do their feet touch the floor?
Okay.
So if they can do those three things, that's a good indication that they are able to sit in the back of a car without a booster seat. Also, you want to look and see, does the seatbelt look like it fits them appropriately?
Okay.
So the lap portion should go down low over their pelvis, so it's actually kind of touching the top of the thigh.
Okay.
And the shoulder strap portion should cross over the shoulder, kind of in the middle of the clavicle. It shouldn't be up resting against the neck, and it shouldn't be way over on the side of the shoulder.
Okay.
And the child should look like they are sitting comfortably in this position, not just trying to impress you so they don't have to sit in a booster seat.
Like with their hands on the seat, pushing themselves up.
Exactly. Sitting comfortably like they could sit that way for a few hours or the length of a, sort of long car ride.
Right. All right. Very good. Very good. So, again, if you have any questions about that, your local fire department may be a resource for you. Pull in and see if there is somebody who is properly trained in child restraint, and they can walk you through it. So, Dr. Roy, let's move over and continue our journey through Grandbaby Bootcamp. There's another couple of topics we'd like to get to this morning, including emotional support for new parents, and
that's an important one. Absolutely,
and what grandparents can do to help support the new parents. It's so easy to forget.
Yes,
the pain of childbirth, but also the adjustment of being a new parent. And talk a little bit about postpartum. Talk a little bit about the support we can give new moms and dads.
Yeah, I think one of the biggest things to remember is that it's a really happy occasion, but it's also really new and really stressful, and it goes on for a long time. So I think remembering that new parents need support even after the first 4 weeks.
Yep. When you say a long time, you mean
months. Exactly. I mean, families always need support, but I think oftentimes somebody has a baby, and people offer a lot of support in the first, say, 2 or 3 weeks. And then parents seem like they're doing okay, grandparents have other responsibilities. It's easy to forget that in many ways the parents are really just getting to the hard part.
Right. The routine, the day in, day out.
And this is where the crying really starts.
And not the crying for the baby.
Yeah, exactly.
Right, exactly. So what is your recommendation? This is not a show about family counseling, but this topic does touch on it a little bit.
Sure, yeah. I think one of the biggest things, and if I could give grandparents a piece of advice, I would say, don't just remember your best days with your babies, remember some of your worst and your hardest. I think
that's really good advice.
I think oftentimes grandparents have a tendency to say, my baby slept through the night by 8 weeks, or my baby never cried this much, or I don't remember my baby ever getting
implying you're doing something wrong.
I think that even if that's not what the grandparents are trying to say, that's certainly what parents feel, and it also reinforces that if the parents aren't doing something wrong, then there must really be something wrong with their baby. And we all, as your kids get older, tend to look back on infancy with a lot of fond memories, and we should treasure those, but also remember that there are some really, really hard times, and we all had them. And when you're up for your 5th night with a screaming baby and a house that you're trying not to wake up, it's not that great.
So babies are really cute, and I see a baby and I get really cute. My wife hates it when I say this, but I'm going to tell you how I spell baby: W-O-R-K. I'll take a teenager any day of the week. So my wife looks back fondly on the infant stages. I look at sleep deprivation, middle of the night, quote unquote, conversations with my wife.
Exactly. They are a lot of work, and they're worth every minute of it. And we
of course.
love them, but
We
they
do.
are a lot of work, and it can be really stressful. So I think just remembering some of those hard times with parents, supporting them, and also acknowledging that we don't always know why a baby cries. Some babies are colicky. To have colic, a baby has to cry more than 3 hours a day straight.
Oh, wow.
More than 3 days a week.
3 hours straight?
Yeah.
Wow.
And for 3 weeks or longer.
Wow. What is colic, Dr. Roy? Is colic just a a phase? Is it an emotional state? Do we know what it is?
It seems to be a developmental phase, and not all babies go through it. I mean, all babies peak in their crying usually between 8 and 10 weeks of life, but some babies cry a lot more than others. We really don't know why. It's not a commentary on their parents. It's not a commentary on the baby, but it's really stressful and hard when it's your baby.
So let's digress for just a minute, and let's talk about colicky babies just for a brief moment, because I don't want to take the show too far off. But how do mom and dad know when the crying should mean a visit to the pediatrician or to the family doc? Like, how do you know?
So I think there are a couple of things to think about. First of all, you can always take your baby to see your pediatrician or your family doctor. And if you have a concern, that's a very sensible thing to do. However, you're not going to want to go to the pediatrician every time the baby cries. I think looking for things that are different beyond simply crying. So does the baby have a fever? Is the baby vomiting? How is the baby feeding? Is the baby having kind of calm and alert periods mixed intermittently with crying? Those are all important things to think about. Babies can cry inconsolably. Babies can cry for a long time. Babies can cry for no apparent reason. Babies can be difficult to soothe. Babies can turn red and purple when they're crying. That's all normal for crying. It's frustrating and it's stressful for parents, and we wonder why are they crying so much? But that's all normal and really typical for babies.
And Dr. Roy, I'd like to mention something else that I know we found very helpful. And in today's society, it's so fast-paced, and sometimes it's difficult to find the time to interact with peers and to make new friends.
Yes.
But finding what my wife used to call a play group or a support group is really, really important, because that's when you realize that all babies cry. And it helps, or all toddlers hit, or some kids do
Everybody
bite more
bites
than
eventually.
others. Exactly, right. And so to the extent that you can be around other parents, and that might mean taking the initiative to meet new people, but to the extent you can be around other parents with their children and observe, it helps you understand that a lot of what you're going through is probably quote-unquote normal, whatever normal means.
Well, normal doesn't mean easy, and I think that's important to remember. But I think that's a good point, and I think it can be very isolating to have a baby sometimes, especially if you have a baby in the winter. Say you were working right up until the time you delivered, and then you have a new family at home with a baby. It's hard to get out. The winters can be so cold and so long. So I think encouraging parents to take that little bit of time to get out, to reach out to groups of other parents, to just get outside a little bit. All of those things are really helpful.
And you can find those types of playgroups and support groups through local churches, through local community centers, and there are a lot of different avenues to
There are a lot of different ones. And sometimes, it's like a lot of different groups. A family might go to one and it's not really the right fit. It doesn't mean they'll never find one, but maybe they just need to try again later or try somewhere else.
Exactly. And so, Dr. Roy, we're coming up on break in just a minute, and before we do, I was wondering if we could wrap up this segment by talking about the importance of respite care and what grandparents might be able to do for mom and dad.
Absolutely. I think it's important to acknowledge that caring for a baby, any baby, but particularly a baby who cries a lot, can be really frustrating. And it's really important for parents to be able to take some time away, to just step away, give themselves a break, clear their heads, and not get too frustrated with their screaming baby. And I think that's something grandparents can really support. And it's really helpful to say, you know what, I'm just going to take her, go out, do your thing, go to the grocery store, go for a walk, go to the gym, fold the laundry, whatever it is that's driving you crazy besides the baby, do it. I'll take the baby.
And Grandma and Grandpa, just know that the baby might scream the whole time Mom and Dad are gone, but you're doing a tremendous favor.
You're doing a tremendous favor, absolutely. And that's what babies do.
Great. So, Dr. Roy, let's cut away to break right now. Before we do, I'd like to give the listeners an opportunity to call in again and ask any questions they might have. Grandbaby Bootcamp, 603-669-1370 is the number. Again, 603-669-1370. We'll be right back.
People are finally doing something about the rising cost of their health insurance. They're switching to Minuteman Health. Minuteman Health could save you $1,000 to $5,100 a year on your premiums. Enroll at MinutemanHealth.org. Savings based on healthcare.gov comparison of the lowest cost 2016 silver plans for all carriers in 03215 for a family of 4, 2 adults age 40 and 2 children under 21, all non-smokers. Provider networks, benefits, and cost-sharing amounts vary.
At Catholic Medical Center, we believe that excellence in healthcare and personal respect for our patients go hand in hand. From our primary care and laboratory services, the Mom's Place, to our minimally invasive robotic surgery, CMC meets your every healthcare need. Our expert specialists and caring medical staff are dedicated to being your lifelong partners in good health. CMC, leading the way with heart. Find out more at CatholicMedicalCenter.org.
We didn't start with the idea of a new facility, but as ideas evolved, they led to the Elliot at River's Edge.
I'm Dr. Joe Guanascia. There was a lot of talk about this being the right time for urgent care.
It's a perfect choice to treat illnesses, accidents, or injuries, or when your doctor's office is closed. I'm Dr. Kevin Rankins.
No one wants to take up time in an emergency room when others might need that time for life-threatening injuries.
Urgent care quickly gets you to a board-certified emergency doctor.
These days, making urgent care easily available and accessible means health care is less expensive for all of us.
Urgent care is a great option when you don't need an emergency room visit. I'm Joanne Waska-Cormier, LPN.
Urgent care at the Elliot at River's Edge. It's faster than an emergency room visit.
You're going to love our care.
Urgent care is open from 7 a.m. to 10 p.m. every day. No appointments necessary. Located right off Queen City Avenue at the Elliot at River's Edge. For more information, go to ElliotRiversEdge.com.
You're listening to On Call with Minuteman Health. This show is informational and not intended to be used as a way to diagnose or treat medical conditions or to replace an appointment with your medical provider. For immediate and medical attention, consult your primary care physician, call 911, or seek care at the nearest emergency department at a local hospital. And now back to On Call with Minuteman Health.
Good morning, folks, and welcome back to On Call with Minuteman Health. I'm your host, Scott Colby, and in the studio with me this morning is Dr. Amy Roy of the Pediatric Emergency Department at the Elliot Hospital here in Manchester. And Dr. Roy is here walking us through, or bringing us through, Grandbaby Bootcamp. So, Dr. Roy, thanks again.
Well, we've almost graduated.
Almost graduated. Yeah, no, we've touched on some really, really important topics. And what I'd like to do is we have a couple more topics we'd like to get through today, and the next one has to do with the appropriate storage of prescription medications.
Yes.
As we get older, grandparents are going to have a tendency to have more prescription medications hanging around the house. And last week, we aired a show with Bill McCormick of the Elliot Pharmacy at River's Edge. He is the clinical pharmacy manager for the Elliot Pharmacy. And Bill was on to discuss the National Drug Take-Back Day and respecting your prescription medications. We touched on this a little bit, but I don't think we can say it enough. The importance of making sure that your medications are stored safely and properly and out of the reach of little guys, little girls.
Don't underestimate them.
And
they're very able little people.
They are, and don't just say, well, it's only my blood pressure medication.
Yes.
So, Dr. Roy, please give us some tips on the appropriate storage and how to keep our grandchildren safe.
Sure. So I think of medication storage kind of in two ways. There's the medications you take every day, and there's the medications that you don't. And grandparents and all adults need to be careful with both of those.
Yep.
So oftentimes the medications that people take every day are in a pill dispenser. You know, Sunday through Saturday, and you put in there your cholesterol pill and your blood pressure pill and your fish oil and what have you. Those canisters are designed to be easy for people to access and to keep pills organized. They are not designed to keep children out, and they are very intriguing. They have lots of little nooks and crannies to them. They are exactly the kind of things that toddlers and young children like to investigate.
Right.
And just because your grandchildren are only going to be there for spring break doesn't mean that they will not immediately notice and take an interest in that medication. So medication cannot be stored around children in those pill organizers.
Okay. All right, that's really good. And it's not just the prescriptions that we write. It's over the counter.
Over the counter, absolutely. I mean, one of the most dangerous over the counter medications that we have readily available to children are things like vitamins, which have a lot of iron in them, which can be very toxic, and Tylenol.
Okay.
And aspirin. I mean, all of those are really very dangerous to children and readily available.
Right.
So even keeping things like adult vitamins up and out of reach is really important.
Right. So obviously painkillers, opioids, blood pressure medications, cholesterol medications, but your over-the-counters.
Your over-the-counters, absolutely. I think people do tend to be a little more cognizant of things like narcotics and things like that, which they know are stronger, and I think which make adults feel some sort of effect when they take them. But oftentimes medications that adults use routinely and don't really notice a difference by taking them one day to another can be, in fact, deadly to children. So these include things like some blood pressure medications, the calcium channel blockers, which are absolutely toxic to children, some oral medications that people take for diabetes. Those really come, even more than narcotics, under the heading of one pill can kill.
I was just going to say that's what you said when we prepared for the show. Is one pill can kill. It's a catchphrase, but it's true.
Yeah,
one pill can kill. So, Dr. Roy, at being a practicing physician at the pediatric emergency department, you must see on occasion children, especially nonverbal children, right? Really young children, toddlers, come through. What are some of the symptoms that a grandparent might look for that would sort of cue them in that maybe the child took some medication?
Okay, so I think that's a great question. I think before we talk about symptoms, we just have to acknowledge that there might not be any for a long time.
Okay.
So nobody should think, oh, I'm not going to worry because I think my child is acting normally. For example, if you take a Tylenol overdose, people don't develop symptoms from those for hours to sometimes a couple of days.
Wow.
But that is still very toxic, and liver damage is happening and becoming irreversible. So the lack of symptoms doesn't mean that an ingestion didn't happen.
Fair enough.
And that's why all medications have to be stored, and medications that people aren't taking regularly also need to be up and out of the way. And parents should and grandparents should check things like drawers and nightstands and somewhere where you might have stashed that medication you were on 2 years ago and then kind of forgot about.
Right. And so we have to pay attention. We have to be diligent.
We do, absolutely.
Okay.
But as far as the symptoms to look for, things like unusual sleepiness, unusual unsteadiness in a child who's walking, vomiting.
Almost like an intoxication.
Exactly.
Okay.
Trouble breathing, those sorts of things.
Okay.
And I think we have a wonderful, free, nationwide resource who is here to help us with all of these types of questions, and that is poison control.
And do you have that number?
I do.
I have it written down, too.
1-800-222-1222.
800-222-1222.
Yes.
Okay.
And that is a nationwide and really vast repository of information on intoxications of all types, not just medications. They also know a great deal about mushrooms, berries, plants, batteries. Sometimes children have swallowed batteries, and poison control actually tracks that information as well. So they are available 24 hours a day, and in the event that it's an ingestion that can be safely observed at home, poison control will talk a family through how to do that. If they need to give them specific recommendations as far as, should I make my child throw up? Should I not? The recommendation really is always not to. But that kind of conversation, that's a good discussion to have with poison control. And they'll also follow up with your child and recommend, when appropriate, that you bring your child to the emergency department.
Okay, great. So again, that number, 1-800-222-1222.
That's them. They're good people. They know their stuff.
Great. Well, thank you. So I think you reinforced what Bill McCormick said last week. So thank you, Dr. Roy. Much appreciated on that. So we have a couple minutes left in the show, and I'm glad that we have time to get to this because it is important. So as a board-certified emergency physician, pediatric emergency physician, working in the pediatric emergency department, you see a lot of different accidents, and you see children coming in where some sort of a first aid attempt was made by a caregiver or a passerby.
Yeah.
And we were talking earlier this morning off air, and I mentioned that we wanted to get into some of the first aid, and immediately what came to mind for you was burns.
Yes.
What do we do for first aid for burns? And I'm assuming, Dr. Roy, that what you're about to tell us really holds true for adults as well as children.
Absolutely.
Okay. So why don't you give us some examples of types of burns and the do's and don'ts of first aid?
Sure. So I think the two most common types of burns that we would see in a household setting are a scald injury, where a hot surface, hot water, hot liquid, has been poured onto a child. Lots of times this will be like an infant who's sitting in someone's lap who's having a cup of coffee or a cup of tea. Sometimes we see those scald injuries in older children, kids who are old enough to use a microwave by themselves and who might put like a cup of ramen or a cup of noodles in the microwave and really get incredibly hot. Occasionally we see those with bathing. So if you're in an older home, you should check the temperature on your hot water heater because it should never go above 120 degrees.
Okay, good.
Some people could practically get boiling water out of their hot water taps. And that's not safe for babies. So scald injuries and then also thermal burns. So these are children who touch a wood stove, touch a hot surface like a curling iron, an iron, or a stove. Regardless of how the burn was sustained, the treatment really is going to be the same.
Okay.
So
what is that?
You want to expose the area. So if there's, clothing or say embers from a fire, something like that got onto the child, you want to take those things off. Take the clothing off, and then you want to try to cool the area. So really, the best way to do that is to run the burned area under just cool running water.
Okay.
And then if there's any blistering at all, anything that looks more than the most superficial, or what we used to call a first-degree burn, certainly seek care from your emergency department or primary care doctor.
And sometimes, Dr. Roy, in severe cases, and this is probably going to be a situation where 911 might need to be engaged.
Yes.
But clothes can melt to the skin.
Yeah.
Right. So in a situation like that, you're not going to want to rip melted garments from skin. But you're going to want to cool it down.
Yes.
Right.
And in that case, you just want to call 911 and apply some cool water.
Okay. So you've given us some good advice. You want to clear and expose the skin, the area. You want to cool it down. What shouldn't we do? What are some of the common things that we might have been told that you no longer do?
So no butter.
Why would you use butter?
I'm not really sure.
But it traps the heat in, doesn't
people
it?
People did. It can. It's also just really greasy and kind of hard to get off. So, and it just doesn't cool it.
Okay.
So please, no butter.
No butter, no oils.
No butter, no oil. Really, the best thing to do is to just cool the burn with cool water and then seek medical attention.
Okay. Is there any particular caution that should be taken on more sensitive areas of the body? What comes to mind is like an eye or anything like that? Or
absolutely.
I mean, we're probably venturing into the call 911 category.
Yes. So I think anything that makes you as an adult really uncomfortable is reason to call 911.
Okay.
So if there is burn to the genital area, substantial burn to any of the extremities, burn to the face, burn to the eye, absolutely call 911.
Okay. And the treatment of a burn, if it's a rash, or as you said a minute ago, what we used to call a first-degree burn, we can handle that typically on our own. What might we want to look for before we see the doctor?
So if it's really a simple first-degree burn, superficial, it's really just a small area of pink skin, which basically is a sunburn. So if it's basically analogous to a sunburn, most of those can be cared for at home, just with Tylenol and ibuprofen, safely stored.
Yep.
And
properly dosed, read the package.
Properly dosed and safely stored, and cool surfaces.
Great.
And if you have a concern, call your doctor or get to the emergency room.
Great. Well, Dr. Roy, I hear the music in the background, and that tells me that we're just about ready to wrap up for the day. Thank you so much for being on the show today.
Thank you so much for having me.
Very,
it's been really fun.
Oh, very informative. Folks, Dr. Amy Roy of the Pediatric Emergency Department at the Elliot Hospital has been in this morning to discuss Grandbaby Bootcamp, some do's and don'ts for prevention and keeping our grandchildren safe. Dr. Roy, thank you once again.
Thanks so much.
Folks, make it a great week.